I will tell you that people with infertility have comparable anxiety and depression rates to people with cancer. There was actually a study that showed that anxiety and depression rates are pretty much equivalent, cancer and infertility, because it's such a life-altering thing.
Hello, everyone. This is Dr. Anita Wanga. I'm here with my friend, Dr. Erica Bove. She specializes in reproductive endocrinology and infertility, and she's also a fertility coach. I'm so excited to have her here on the show so she can share what she does and how she managed to come to this place in her life where she's a physician and also a fertility coach. Dr. Bove, please tell us a little bit more about yourself and your journey to also becoming a fertility.
Sure. Thank you so much, Dr. Longa. It's such an honor to be here. So I am an OBGYN by training, which means I did a 4-year obstetrical and gynecology residency after medical school. And then I really loved the most the fertility aspects of that field. And so I then decided to do a 3-year reproductive endocrinology and infertility fellowship, which basically focuses on how to help people get pregnant who are having difficulty, but also how to help people with the other endocrine stuff that can happen that can be very bothersome. Menopause symptoms and puberty and people who have different anomalies that make it more difficult to have female functions that work right. So that's the full field. And I've been out of training for about 9 years now. And as I started seeing patients, I really realized that there is a huge gap in how people could make decisions about their care. So like I was doing my best, I was reviewing their test results, their treatment options, et cetera. And then people would look at me at the end of the consult like, how do I even make these decisions? And what do I do next? And so then at the same time, I was also engaging in coaching for my own personal reasons, like relationship coaching and parenting coaching. And as I decided to become a coach, I realized like these are the skills that my patients actually needed to be able to make better decisions about their care. So that's when I got the idea. I'm like, maybe I'll become a fertility coach and combine my knowledge of being a fertility specialist and the tools of coaching to really help people make empowered choices and feel less stress during the process of fertility treatment. So that's a little bit about how I got here. I founded Love and Science Fertility about a year ago. It's growing. I do one-on-one coaching. I do group sessions. I have content. I have a podcast. It's been absolutely amazing.
Wow, you are incredibly busy. You're a mom, you are a physician, and you're a fertility coach. How do you find time to juggle all of these activities?
That's a great question. I think self-care is key. Like Dr. Funke should be proud. Like I always sleep at least 7 to 9 hours a night. Last night I slept 10. I exercise. I really feel that if I'm going to be in such a helping profession, I really need to fill my own well so that I can keep going, sustain this work because it's so meaningful and important, but it also does take a lot to be able to be fully present. So that's the first thing. And the second thing is I was able to find a job that allows me to work not quite full time. And that does give me a little bit of extra time where I can choose to do what I want. So there are some times when I can really focus on my coaching because I don't have clinical responsibilities. And my appointment is just a little bit less than what it would be if I did that and only that.
Wow, that's incredible. And I love how you practice what you preach. As physicians, we're always telling our patients, you sleep, you should do this. And you're the real deal. So that is amazing. And for our audience who've never heard of REI, what is, or I should say, reproductive endocrinology and infertility, what exactly is that specialty? How is it different from, say, regular OBGYN?
Sure. So I'm in the US. In the US, we have 4 years of college, 4 years of medical school, and then you choose your residency. So I did a 4-year obstetrics and gynecology residency program in New York City. I got board certified in that field. So probably delivered over 1,000 babies and really helped to learn all the different gynecological nuances. And then some people decide to do that and practice full spectrum obstetrics and gynecology in their practice, delivering babies, doing hysterectomies, helping people with abnormal bleeding, all those different things, women care. But there are different branches off where people can become subspecialists. One of the subspecialties in the US is GYN oncology. So people who focus purely on female cancer, like endometrial cancer, uterine cancer, ovarian cancer, cervical cancer. There's also people who focus on high risk obstetrics, and most of these fellowships are 3 to 4 years additionally. So people who really want to focus on either sick mothers or complicated pregnancies and consulting on those sorts of problems. There's also people who focus on urogynecology. So when people have problems holding their urine or have other problems with their organs falling out due to various reasons, weakness and such, they focus on those sorts of problems and surgeries. And in one of the other branches, which is the one that I do, is called reproductive endocrinology and infertility. So it's really a gynecology-based specialty. It is all centered around the reproductive axis. So it's super interesting. Like the brain and the ovaries are always in communication with each other. And obviously the uterus is involved in this conversation as well. And so when there's a problem, you have to figure out, you think as an endocrinologist, somebody who focuses on the hormone side of things, that's what endocrinology really is, and you figure out where the communication is getting blocked. And so that's part of it. Is this a problem at the level of the brain? Is it a problem at the level of the organs like the uterus and the ovaries? Or is it something altogether different that's interfering with the process? So that's one thing that we think about. And that those sort of alterations can be reflected in really bad menopause symptoms, or somebody who doesn't, get puberty at the appropriate time, or somebody who just keeps bleeding and bleeding no matter what they do, whether they're on birth control or not, just people who just bleed for various reasons. We help with that too. People with hot flashes, people with sexual desire or arousal issues, like there's really a full spectrum of care that is involved in with the reproductive hormones. And so I would say like the training involves a little bit more in-depth understanding of the actual hormone molecules and how they bind to the receptors and what are the different things that can influence and cross-react at those levels. There's also a surgical component, which also looks at when there's physical problems with the uterus that make it harder for bleeding anomalies or fertility to take place. We do that as well. So if somebody's born with a septum, or they're born with their anatomy not connecting, or say they're born with something else that might make it more difficult, or say something's acquired, like somebody wasn't born with fibroids, but all of a sudden their uterus is just riddled with fibroids, and that's affecting their ability to conceive, or if their fallopian tubes are blocked, or if they have some ovarian issue, then we can do surgery and intervene in those ways as well. So it's actually a pretty broad subspecialty. It does encompass a lot of things. The current job I have, I will say, is probably the most full spectrum job I've ever had. I actually also do contraception management. So I help people, I put in IUDs. I help people with sort of complex family planning issues as well, which is in and of itself another branch. I'm in rural Vermont, so it's a little bit more broad spectrum than, say, maybe I would see if I was in a city. So it's all these different touch points of reproductive hormones, reproductive care, of helping people to get pregnant and stay pregnant, but then also all the other things that can happen with the reproductive axis that create problems in quality of life.
Oh, that is so fascinating. And even for me as a physician, you're educating me, because in my mind, I thought REI focuses more on fertility, but I didn't realize, in the back of my head, I knew there's other hormonal issues that can affect fertility, or even just other hormonal issues that a lot of my patients present to me with that I don't have the skills or the bandwidth to manage. So I think this is extremely useful for me as a physician. So in addition to helping patients that want to plan their family, you mentioned that you help patients with other hormonal issues. What are some of the other common hormonal issues that you'd help patients manage?
Absolutely. So I will say I see a ton of people with what's called polycystic ovarian syndrome. So that is 10% of reproductive age women have this. You can get to it through many different pathways because it's a syndrome, but it's usually a constellation of extra hair, extra acne that is bothersome to people. So I saw a woman the other day in my practice, and she had a full beard actually due to this. I think it's due to this. I have to sort it out. Obviously, it's creating all sorts of problems because she's misgendered and she has all this extra hair that she has difficulty getting rid of. And so hopefully we're going to help her get back on her pathway to more hormone balance so she doesn't have to deal with those things as much. Extra hair, acne, irregular cycles, lack of ovulation or infrequent ovulation, so it's harder to get pregnant. And also with that comes, and this is probably of interest to you too in your practice and holistic health, people have a really hard time even maintaining weight, let alone losing weight. So their weight tends to creep up over time. Sometimes people can have fluctuations of 40 and 50 pounds. When the weight comes on, it has a hard time coming off. It's because on the other side of the coin of the reproductive problems associated with this disorder, there's also metabolic problems. And so they basically have a harder time processing nutrients, or maybe an easier time processing nutrients if they just stick and stay. And if one person without PCOS eats a bagel, their body does what it should. But somebody with PCOS, it might store those carbohydrates really efficiently, and it becomes harder for them to lose weight. They all say, Dr. Bove, I swear I'm eating 1,200 calories a day. I'm at the gym 6 to 7 days a week, and I'm doing all the right things, and nothing is budging the needle, and I'm so frustrated. I help people with that problem as well. I can really help a lot with the extra hair growth and the acne symptoms. I work with a really great group that really helps with weight management. So that's been really helpful, because the great thing is people start to optimize their weight. Usually they need assistance to do this because it's an uphill battle, right? Also, the other symptoms start to get better as well. Sometimes they start to ovulate on their own, and sometimes they don't even need my help at all. So that's really where the holistic care comes in. You get to, it's a privilege to do this, to really understand what somebody's concerns are, make sure that they have the appropriate diagnosis, and then get them what they need truly to live their best life.
Ah, fascinating.
Yeah.
And I'd like to ask you more questions about other hormonal issues that might cause challenges with infertility. But there's also another component that you do, which is fertility coaching. So tell us a little bit more about what a fertility coach is and how they can help somebody on their journey to having a family.
Sure. So just as reproductive endocrinology is a branch off of OBGYN, fertility coaching is a branch off of life coaching. And so we've all heard of like life coaches, which I think have become more popular in the last few years. People compare it to therapy. It's a little bit different than therapy because you don't have the in-depth training that a therapist does with all the different therapeutic modalities. But for me, I found the best school I could to get my coaching certification. And it's really action oriented. So you meet the person where they are that day. You examine their thoughts and their feelings because our thoughts influence our feelings, influence our actions, and then our actions influence how we show up in the world. And so that's a general framework of at least the coaching school where I went. And so what I've done is I've taken those tools and applied them to the fertility journey and figured out how to help people with the negative thoughts that they're having about their journey, their hopelessness, their despair, their thoughts that this is never going to work, and really shine a light on those thoughts and those feelings and help them to have better thoughts and feelings that serve them such that their actions are more in line with what they need to do and they ultimately get to the result that they want, which is family building. So it's basically using coaching tools for the fertility journey in a way that helps people get out of their own way, have thoughts that serve them. And in my mind, what this is doing is really aligning all the vectors so that they can have the highest chance of success.
Ah, that is amazing. And I
Yeah.
think it's so powerful because there is this thing that your reality is your thoughts. So if you see or frame something as negative, then it is negative, even if from the outside looking in, other people see it as positive and vice versa. So I think that is so powerful. What are some of the common negative thoughts that people will come to you and overcome when they're struggling with their fertility?
That's such a great question. The list is truly endless, but I will say one of the most common things is I'm too old to be doing this, or I'm too old to get pregnant, which age is just a construct. People tell me that when they're 30. I had a 28-year-old recently who told me that they thought that they were too old. So again, we look at these, we challenge the validity of these, but age is something that I talk about a lot because people just feel a certain way at different ages. And a lot of that is based on their own limiting belief system. Another thought is this is never going to work. And so I think what happens is when people have already gotten bad news, the brain is very protective, right? That's how we survive the world. We have our coping strategies. They've served us in the past. But what we do is we protect ourselves so that we won't risk getting hurt again. And that starts to work against us. So if somebody's only gotten bad news or they've only had miscarriages, what the brain offers them is this is never going to work, or I'm foolish to even get my hopes up, or like it's my fault that this isn't going to happen. And then people end up in a shame spiral. And by having those negative thoughts, then their actions like follow. So they're less likely to do what their doctors ask them to do. They're caught in these shame spirals, negative thinking. Their whole body is physically stressed out and fearful and anxious, which we know stress affects the process. And so then the result is likely for it not to work out. Again, this is much more complicated than just thoughts. This is why I call my practice love and science fertility, because it takes both. It takes the love to help people get into the right mental space, to relax, to trust the process, to believe that it's possible. And then that then opens the gates for the science to actually work at its highest level.
Wow, that is so powerful. And I think in any part of our journey or any goal that we're trying to achieve, if we're more relaxed about it and more hopeful and more optimistic, we're more likely to get the positive outcomes that we desire. And I think as a fertility coach, reframing people's thoughts is definitely true. And their stress levels going down, they're more likely to get the outcome that they desire, which is the desire to child. And speaking of the fertility journey, what are some of the strategies beyond, or maybe more in depth, that you give your patients to help them reframe some of those negative thoughts?
Sure. I think that it's really important to challenge the thoughts that people are having. So the first step is really shining a light on the current thoughts and the feelings. And then really asking the client, are those thoughts true? Or is that how you want to be feeling about this? And that in and of itself brings a lot of awareness. So then once we see how people are thinking and feeling, which again, 95% of this is in our subconscious unless we actually look at it. So people are like, oh my gosh, I had no idea how much this was affecting my actions and my thoughts and my feelings. I just had no idea. Once people understand that, then they can start to challenge that with the help of me as their coach. And so once we do that, I might ask them the question, like, how do you want to feel about the situation? Maybe most people don't want to feel hopeless about it or powerless or any of those negative or fearful or anxious. Most people want to feel hopeful, or they want to feel grounded, or they want to feel assured that it's going to work, or even just accepting. A lot of it is resisting reality, which creates not just the pain at that point, it becomes the suffering because we're resisting what is. So a lot of what I do is I help people with accepting the reality of infertility, and then people can then make their most empowered choices because they actually have energy that they're not spending resisting reality. We bring in the serenity prayer a lot. Grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. Coaching really does help with those last two sentences because we have a lot more agency than we realize. And part of what I do is I help people have that awareness and then take back their power in a way that puts them back into the driver's seat, whether it's, asking their fertility specialist better questions, or maybe it's saying, these are my values and let's bring my values into this conversation because I actually wanted 3 children, not 1 child. And can we still keep that part of the conversation? Like all these various things come up, but it's really like awareness and then showing people really they're the ones who generate these ideas. I'm their guide, but what do you actually want? And then how can you reorient so that your thoughts and your feelings and actions align to head in the direction of your desired result. If that makes sense.
Yes, absolutely. That makes sense. And I think that is so powerful. And the next question I want to ask you is, if a female is coming to you for fertility coaching, should she come with her husband or her partner, or do you just focus on one coaching? What are your thoughts on that?
That's a great question. So, I have my doctor hat and my coaching hat, and I never really take off either. I will say it really just takes one person in the dance to change for the whole ecosystem to change. So, when I am seeing somebody in my office in my doctor role, when people come in for the first time, I love seeing them as a couple because sometimes people are on slightly different pages about what they want, and that's very useful. Some people have not even had the conversation about how many children they want to have. And if I'm just seeing the female and that say it's a heterosexual marriage or relationship, if I'm only seeing the female, I might miss a lot of information that I might get otherwise, right? Oh, and so that's really useful. Also, I think sometimes like when people have been living together for a long time, they're able to shed light on the other person's experience that maybe I couldn't elicit from just one person alone. For instance, the other day I was seeing somebody who I asked the question about hot flashes. Hot flashes are a big deal if you're trying to get pregnant because it's often a sign of low estrogen. And that could mean that maybe somebody's ovaries are acting older and somebody might even be in perimenopause when they're trying to conceive. Really important to know. For instance, I asked somebody the other day, do you have any hot flashes? And she said, oh no. And the husband was like, wait a second. Yes, you do. Actually, I beg to differ. And in the chart, I actually wrote like, patient denies hot flashes, but partner says that these are actually quite frequent. And I just said, you know what, we're not going to solve this. We're going to agree to disagree. But now that I have that information, I'm going to interpret. I will say similarly, like when I'm wearing my coaching hat, though, I always invite the partners to join, especially in the beginning when people are deciding if it's an investment that they want to make in themselves, because a lot of times people make these financial decisions together. The majority of the time, I usually just get one person and then either they make the decision themselves or they consult with their partner. But I always leave it open because I think if the fertility journey is driving a wedge in the relationship, as it very well can, it often does, that sometimes it's helpful to help people reorient, like zoom out, realize what they have in common, realize what the vision was initially. And sometimes it's financial concerns, sometimes it's other things, but really helping people to say, okay, what's important to you? What's important to you? What are you most concerned about? What are you afraid of? Because unless people are taught that early on, it's really hard. People just don't know how to communicate about these things. So it's really, helping people find their voice and facilitating conversation in a way that makes sense. So I can do that with, say, my own client and give them tools, but I always invite the conversation because I think it really is a joint decision. And when people are having a hard time communicating their feelings, that also influences the things that they want and need and the requests that they make. And so when I can help people, feelings, needs, requests, help them with that whole trajectory, I really do think there's value when the other person is involved as well.
Wow, that is so powerful. Definitely, it takes two to tango, and it takes at least two different individuals to have a child. And I like what you're saying also about helping couples. And specifically, I wanted to ask a more specific question about tips for couples who are struggling with infertility and communication. What tips would you give, say, a couple who say either they're not being direct about their feelings about infertility or it ends up being a fight? Would you have any general tips to help couples communicate better if they're struggling with infertility?
Absolutely. So the first thing that comes to mind is I think sometimes people, this notion we have of romantic relationships, this is really the only time in history that we've put so much stock in one person, right? Like we expect this one other person to meet like every single need, and that's just not fair. So I think that in order to have the best conversations with partners, it's actually important that we widen our circle of support to include other people. Maybe it's a parent, maybe it's a few girlfriends, maybe it's somebody else, an online friend, through a fertility forum. I don't know. But I think that what I found is that when somebody leans on another person too heavily, or that's like their only support person, that's when the relationship seems to get stressed the most. And it's if you can diffuse the burden, especially with people who really get it, like female friends who are going through something similar, then the communication that does happen between the romantic partners is less pressured and there can be more progress. So I know that might seem like a little bit counterintuitive, but it really does make a difference. So that's the first thing. And then I think the second thing is really like finding language of how to express our emotions and our feelings. And a lot of times we just don't have the words. Like one of the books I recommend to my patients and my clients a lot is a book by Brene Brown, Atlas of the Heart. It actually goes through, I think it's 88 different feelings and describes what that feeling is. And I think the more nuanced language we can have for how we're feeling, the better conversations that we can have. First, we have to tune into ourselves and feel that feeling. But then when somebody asks us how we're doing, then it takes that vulnerability and say, you know what, I actually think I might be feeling shame today, or I think a part of me feels distressed that this might not work. Really clarifying what the emotional state is and then being able to be vulnerable to share that with another person. And so I think taking a sort of team-based approach, a resourceful approach, holding space for the other person, I think can be very important. And understanding that there may be differences in perspective. And so getting curious and listening is really important to understand where the other person is coming from. It's not just about proving your point. It's about understanding what it's like to be the other person. I will tell you, especially in heterosexual relationships, the men often feel very powerless, right? It's the woman who's going through the majority of the treatments. They're watching their wives suffer. It's very painful, and they just want the suffering to stop. So a lot of times there's, babe, let's just stop this whole thing. Let's just stop treatment. This is too much. We'll be fine on our own. We'll be fine without a family, without children. And then the woman's, oh my gosh, he doesn't believe in me. He doesn't support me. He doesn't like, and it's not about that. He just wants the suffering to go away and he feels powerless. Men don't like to feel powerless. So then it's, okay, how do we then bring back the agency, bring back the power, bring back the understanding so that the men do not feel that powerless way, right? They have their agency back. The women can express themselves. And again, there's all sorts of different relationships here, but this is just a very typical example of what I see, so that people can then not be making such reactive choices and blame each other, but can actually look at things more objectively and say, what do we need to get to the next level? What do we have in common? Where are our differences? What resources do we need to pull in to be able to make these choices? And so it becomes a much less charged situation when people can be like, one thing I love to say is it's me and you versus infertility, not like me versus you. I think that distinction makes a big difference.
Oh, wow. That is so powerful. And thank you for recommending that book. You said Atlas of the Heart by Brene Brown.
Oh, it's fantastic.
Yes, I have to look up that book. That sounds very fascinating. And I love how I'm realizing you're not only just a fertility coach. It seems like at some point in time, you're also teetering into being a couples coach at the same time.
100%. It was so funny because I went to med school to be a psychiatrist. And then as I was in medical school and I took this quiz of what specialty should you go into. I don't even know where it came from. And the things that came up in this quiz are like to talk with couples about their problems and to help people with their sexual health and like all sorts of things. And I was like, maybe I need to reconsider here. Like none of this, obviously there's the thing I love about psychiatry is like the meaning and the motivation and helping people overcome their struggles mentally. But I think that can be done in the context of women's health because these issues are so close to home. and the stakes are very high. And so I also love the surgeries, of course, but it's like helping people to tap into what really matters to them and then figure out a roadmap to achieve those dreams, really.
What you're doing is so perfect for you. Like, it was so interesting. Even before we started down the trajectory of what a fertility coach is, I'm like, you make a great psychiatrist. So it's so fascinating. That was your original intent, and now you've married both of your loves. It's fascinating. I love it.
Thank you. Well, so funny because I just like you, I love bookstores. And so like whenever I go into a bookstore, I'm always drawn to like the personal growth and development spirituality sections. And it's just funny, like sometimes you just have to relax into who you are. You can't be like, why do I do this? Or why am I not? Why don't I go to fiction? I admire people who read fiction. And to be fair, I'm reading a fiction book right now. I'm in a book club. But the things I'm most drawn to, I think that's when where your passion and your purpose align. I think that's when we can do the most good in the world.
Yes, absolutely. And I can say for sure, it sounds like this was the path that you were meant to go down even before you probably started your medical school journey. And
Thank
speaking
you.
of psychiatry, would you say there are certain psychiatric conditions or certain medications that might make it more difficult for an individual to have a child?
Oh, yeah. So that's such a great question. I think one thing that we have to understand is that the brain has hormone receptors inside of it. And so a lot of times, even something as simple as premenstrual symptoms that where people get very moody and very upset that happen right before PMS type things, but there's also something called PMDD, which is a more kind of the mood symptoms of PMS. I think we don't really give enough credit to the fact that like women are not crazy. When hormones rise and fall, there's a lot of symptoms that sort of spill over into how they feel, how they can communicate, how they are in the world. And some women are more sensitive to those things than other people. And so again, even this week I had a conversation with somebody who was considering in vitro fertilization. And she was like, you know what? I just am really concerned because every time I, have a period, I just get so sad and what's that going to be like? And so we talked about it. So I think knowing your own body and how you respond to hormones and hormone alterations, like most of us have experience from menstrual cycles and those sorts of things, like just understanding, am I a person who is sensitive to hormones? Do I seem relatively unaffected? That's a really important place to start from. I will tell you that people with infertility have comparable anxiety and depression rates to people with cancer. There was actually a study that showed that anxiety and depression rates are pretty much equivalent, cancer and infertility, because it's such a life altering thing that and such people have a lot of hopelessness as well, that it's really hard. I always leave room to discuss that because I want people to feel better, right? It feels horrible to be anxious and depressed. And also, these are treatable conditions. And when those conditions are treated, people often have better outcomes as well. So it's all connected. I will say that sometimes people have like medical conditions where they have either significant like heart anomalies or lung anomalies, lungs get squished during pregnancy, where they meet with a high risk OB doctor. And maybe it's not the safest thing for you to get pregnant. I mean, there are only a few of those situations, but when that happens, there are actually people who do gestational carriers who can actually carry a pregnancy for a couple, and then the intended parents get to raise that child if somebody is not able to carry. So sometimes we can even do IVF for a couple and then have a gestational carrier carry the pregnancy, and then those people can still be parents with children with their own DNA. So that is one possibility. From a mental aspect, I will say, thankfully, treatments for mental health have gotten a lot better. And I do think that the anxiety and depression don't get better once people get pregnant. There's actually data that postpartum is a particularly vulnerable time for these people. And so we have to really think full spectrum in terms of not just pre-pregnancy and pregnancy, but postpartum. There are certain things like bipolar depression is a really tough one because I think the mania can be very difficult to endure, very difficult to treat. And some of the medications for bipolar depression can also have more safety concerns for the growing fetus as well. So that's the importance of really seeing somebody who takes a full history. I know in your practice, you're very much into holistic care, who really sees the whole picture. It's not just what's your diagnosis and how do we treat you, but what are your other medical concerns? What medications are you on? Are you on a prenatal vitamin? Are you on anything that might harm a growing pregnancy? Like, for instance, some of like lisinopril, which is a blood pressure medication. That's not a great medication to be on. Sometimes people, and I love the GLP-1s that have come out, but we don't really have a lot of data in pregnancy. So we proceed with caution and we say, okay, why don't we set a weight loss goal? And then once you get to that goal, with the help of your primary care doctor, endocrinologist, stop the medication and have a washout period and then try to get pregnant. So that's why I'm so thankful that our training is so long, because it really gives us access to see all these different nuances and situations. And then we can predict who might have difficulty and be able to optimize things preconception. I'm trying to think. Sadly, I've seen some women who are in abusive relationships, and that is absolutely somebody where I put the hard stop on that and make sure that I could get somebody the safety. And oftentimes people will leave a relationship or they enter counseling and the relationship gets better. Like, it's one of those things where it's a biopsychosocial approach. It's not just looking at somebody on paper and seeing what's going on, but you have to read between the lines. You have to understand if there's a history of trauma. That in and of itself can make it more difficult. I have this theory that trauma is stored in our pelvis, and diseases like endometriosis are more common in people who have had a history of trauma. And so just really understanding what has somebody actually been through in their life, how is an encounter with an OBGYN potentially going to make that worse? And what do we need to do to create a supportive environment so that somebody's whole self is being seen and that we can create the best treatment plan possible for them?
I love what you're saying, and I love your holistic approach. And it's so fascinating. And there's so many questions I could ask. But I think my next question is going to be, what are some natural ways that somebody can optimize or improve their fertility or their chances of having a child?
Yes, absolutely. So the first thing I would say to that is, if having a family is a priority to you and you're listening to this podcast, try on the sooner side. And this is not some sort of anti-feminist rant about everybody should have children early. It's about that we need to understand our bodies, and that the best way to optimize natural fertility is to have children when our eggs are healthier, because a lot of people know along the way that they want to be a mom, but either they haven't met a partner yet, or they are on a career trajectory that makes it so that they're not going to be at a resting place until they're in their later years. And so if having a baby is a priority for you, either see somebody about freezing your eggs, or if you have a partner and you guys have talked about kids, but you're just not sure it's the right time, there's no great time to have a kid. And really not waiting until the eggs are older and not working as well, but really trying on the sooner side, if possible, is one of the best ways to optimize natural fertility. Now, there's a lot of things, like we talked about the serenity prayer. There's a lot of things we can control, a lot of things we cannot control. So one of those is age. Say you meet the love of your life at the age of 42. That's a more complicated situation. And what I would say is there are certain things about natural fertility that are important. If cycles are 28 days, usually, or say even 30 days, you can usually subtract 14 days from that interval, cycle day 1 to cycle day 1, and that will tell you when you're ovulating. So what I want to say is, this is how you calculate your fertile window. You figure out when you're ovulating either through doing math, right? So 28 minus 14 is 14, so you probably ovulate around day 14. 30 minus 14 is 16, you probably ovulate around day 16. And then the fertile window is 5 days before that ovulation day until the day after, because the eggs last less time than the sperm inside the body. So if the sperm lasts like 2 to 3 days once they're in the body, and the eggs only last 12 to 24 hours, you want the sperm waiting for the egg. The way that I think about this is like a traditional heterosexual marriage where the groom is like waiting at the end of the aisle for the bride to come down. That's how I think about it in terms of sperm and eggs, because sperm lasts longer than eggs. So the fertile window is truly 5 days before the egg is released until a day after the egg is released. So that's the fertile window. Getting together about every other day during that time should be sufficient so that there's sperm always there. So that's one thing. Another thing is, and you'll appreciate this, Dr. Longa, is like the lifestyle. I think sometimes this is in that bucket of things we can control, even if it's really tough. When I take a history on my patients and my clients, I find a lot of people who are smoking cigarettes or chewing tobacco or using marijuana to relax. And those things that we put inside of our body, even if they help with like stress management or anxiety or whatever else, we enjoy them. Those sorts of things really affect egg and sperm quality in a way that when people stop those things, fertility often gets much better. So really looking at the things that are inside the body, and oftentimes these are like recreational things. Even too much caffeine can really affect this as well. I'm not saying cut it out entirely, but it's really about being very mindful about those more toxic substances and either reducing them significantly or eliminating altogether. That can make a huge difference. Another thing is the food that we eat. I really believe that food is medicine. And, if we're eating junk food all the time, or we're just not taking care of our bodies, we're not exercising, we're not sleeping, all those things are not good. They're not good environments for egg health and optimal fetal health. So really, sometimes infertility is a wake up call to be like, okay, what do I need to change to make this process more likely to happen? I don't think we should be changing every single thing at once, but really looking at the lifestyle in terms of cleaning up the diet, cutting out toxic substances. And another thing I get asked about a lot is weight. I think it's really important to understand that weight and health are not the same. There are people who are very unhealthy at lower weights, and there are people who are very healthy at higher weights. But we do know on population level data that people who are at least overweight, if not obese, definitely in the obese category, have higher pregnancy complication rates. It's harder to get pregnant, it's harder to stay pregnant. There's more birth defects, there's more diabetes in pregnancy, there's higher C-section rates. There's all these things that go along with carrying additional weight. And every single person has their own fertile zone, but it's really hard to know what that is unless somebody's been pregnant before and carried a baby to term. And so if somebody is carrying extra weight, it's part of the conversation to say, sometimes they even say if somebody's young enough, hey, let's take a pause for 3 to 6 months so that we can really optimize this. Most people who are in that situation have tried a lot of other things that haven't worked. Get an exercise regimen, get a dietary regimen that works, sometimes even go on pharmacotherapy. Sometimes not. I know we share similar thoughts about pharmacotherapy, but really help them optimize their whole life so that this whole process can work better. So that's really important for optimizing natural fertility. I think those are the main ones. And then stress reduction. People ask me all the time, does stress make a difference? It absolutely does. It's a really hard thing to study. People have looked at acupuncture, they've looked at other various stress reduction techniques. And that's really what I approach at Love and Science, is really trying to help people reduce their stress. Really, not only does it feel better, but it really helps with outcomes as well. And so that's tricky to do, easier said than done, but there are very concrete things that we can do that really make a difference.
Oh, that is so fascinating. And definitely, I think the lifestyle factors, what we eat, our exercise, make
Yeah.
a big difference in our overall health. And it makes sense to make a difference in somebody's fertility journey. And I think another question I can see patients asking is, are there any supplements you tell them to take to help them improve their chance of having a baby?
Yeah, great question. So I know I'm a believer that if you're going to get something, you can get it in your diet. It's better than taking a pill. So really like eating a rainbow a day, focusing on whole grains, really being mindful of avoiding as much as possible processed foods, plant forward diet. I do think that high protein is helpful, but there are some data that looking at plant forward stuff really can be helpful. And also, I love helping people talk about intuitive eating. Like people are not taught how to eat for them personally. All the dietary stuff, there's some good guidelines out there, but a lot of it is like, how does this food make you feel? And if you have dairy and it makes you feel terrible, then don't do that. If you have XYZ, don't, like, really, for me personally, like eating a handful of almonds makes me feel like I'm on top of the world. That's fantastic because those are good for me. So again, like a lot of it is tuning into our bodies and figuring out what we need specifically. So that's what I would say is really like helping people with those sorts of things that they may not have been taught, but in a way that helps them with their outcomes. Was there another part of that question that I did not answer?
Oh, no, that is perfect. I think it's you targeted it or you answered it perfectly. I think that's very true. I totally agree.
Oh, supplements. Yes. So
Oh,
yes, there is. So to finish out that question, so every single person who's trying to get pregnant should be taking a folic acid supplement, at least 400 micrograms a day. It has been shown over and over again that reduces the risk for something called neural tube defects, which is basically like the brain and the spinal cord when those form, that those can have difficulty forming if people are folic acid deficient. So every single person, those are in most multivitamins. It doesn't matter if you take a gummy or a pill, whatever. You don't even need a full multivitamin as long as you're getting the folic acid. But that is something that oftentimes we don't get in our diets, and it's really important to take. There's also a supplement called coenzyme Q10. I'm not a huge supplement person. Like I said before, I really do think we can do most of what we need with dietary stuff. But coenzyme Q10, there's animal and human data that it makes a difference in egg health, which is one of the biggest problems that we treat, especially as women get older. So coenzyme Q10, 200 milligrams, 3 times a day. That's what the study showed. Really helps with egg quality. And so, again, it's not the only thing. It's not like a silver bullet that's going to fix everything, but it's one of those little vectors that if you align enough things, hopefully that can get people over the threshold so that they can stop being subfertile.
beautiful. That there's a lot to learn, and I'm hearing a lot of people talk about coenzyme Q10. I've heard a little bit about it. This was a couple of years ago in cardiology for people taking statins. That was trendy for a while, but then I think our data was not so good. But I think there's a lot in medicine that we do not necessarily know yet, especially about supplements and other forms of medicine like Eastern medicine as well. So I'm excited to see what we incorporate and learn in the future. But I think we're going to probably close. I think I've really enjoyed talking to you, and I still have so many questions. So I'm going to have you back. There's too many topics to even touch on. So I'd love to have you back if you're willing to come back. And for our audience, I'm sure there's so many people who have so many questions. They want to either work with you or hear more about what you have to say. Where can people in our audience find out more about you?
Absolutely. So the most comprehensive place is my website, and that's loveandsciencefertility.com. There you can book a free discovery call with me. You can see different free resources I have, the podcast. Everything that I do is under Love and Science Fertility. So my podcast, which is on all the podcast venues, Instagram, Facebook, follow me, rate my podcast. And if you want to come on, Dr. Mwanga, we can talk about some other things to my podcast. But yeah, those are the best places. You can tell I'm passionate about what I do. I love helping people get the tools they need to get to the other side of parenthood intact.
Thank you so much. We will make sure that we have all the links to your website, your podcast. I think you're on several social media sites, so we'll make sure to put the links below so that our audience can reach out. But thank you again so much for being on the show, and we look forward to having you back.
Thank you so much, and thank you for all you do for your patients. They're so lucky to have you, and I think we need more people who take a holistic approach to health and to medicine, and that's what they get when they come and find you. And I love your emphasis on medicine reduction as well. I think we're so aligned in so many ways, and I cannot wait to have these collaborations with you.
Thank you.